Yeah. So, anyways, Eric,
Yeah. What's going on?
good morning. Good to see
Good
you.
morning. Good morning. It is good to see you, Christian. It's been a solid day so far. Willie didn't wake me up until 6 a.m. today, so we're got a little bit more sleep than yesterday. We'll just say that.
Well, yeah, you've been putting her on that treadmill. That thing looks awesome.
That is such a dude. That's a sturdy machine. I'll say that. That thing, like, I think can hold up to like 300 pounds, and so I
So it's
might just
also
start.
for
I
you.
might start walking on it. But no, yeah, that's it's a sweet thing. She's starting to get the hang of it. At first, she didn't want much to do with it. It was super scary to her, and she didn't really understand the concept. And but now she's starting to walk a little bit more and. Um, it's honestly a great way to just like for her mentally to get some energy out because she's trying to figure out how the heck does this thing work, as much as walking slash running on it. But yeah, no, it's been good, man. The treadmill's been it's been sweet.
Yeah, she seems to like it a lot. I'm just always impressed by how easily you picked up on dog training. Like, I don't know if I've told you that, but like you're doing a really good job.
Well,
Yeah, so
thank you,
it's
man.
sick.
I appreciate
Yep.
that. Yeah. No, and I feel like I don't know what I'm doing at all. But I think Willie just makes it super easy. She makes me look good because
That's true. She is really good.
she's
Yep.
really good. Until this morning when we had our meeting right before this. I don't know if you heard her like yelp in the background, like
No.
halfway through it. She's been very playful this morning and she's been wanting to play with me. And she yelped at me. And I was like, kind of like, okay, let's calm down. And then she started like really trying to play. She actually got me pretty good, left a freaking bruise on my leg from her teeth. So I go put her in a kennel, give a little social isolation time. She's got to calm down.
Yeah, and the last thing I wanted to tell you was that you have good hat game. I have not seen
Appreciate
that one yet, and I see a lot of
it.
your hats.
Appreciate it.
But I don't know if people know, but we also have a bird logo that I think is pretty cool looking. But that one
Yeah.
actually looks way cooler. I like
Yeah.
that bird logo a
Yeah.
lot. Yeah.
Like so this is called so the brand is called Waggle. It's a golf hat. It's a golf brand. You can get polos and whatnot too. And they kind of make like unique stuff. And this one I saw online last week and I'm like, that's actually a really like sweet hat. Just a cool little mallard flying on the front. Like it fits me well. I kind of have a bigger head and it fits me really well, so I love it. But yeah, no, I appreciate that.
Are you a Key and Peele fan?
I've watched some of their skits. Like I know some of their skits off and on, but I never like followed them super closely.
Yeah, there's one about hats and two guys going back and forth about who has better hat game, and it just gets absurd, of course, as all their skits do.
Yeah, yeah,
But
yeah.
I highly recommend you watch that one if you haven't, because that's
I
kind of how I
should.
feel right now, where I'm going to
Yeah,
come back next week with an even better hat.
yeah, yeah. There you go. I appreciate you're really hyping me up here before we get into this content. I'm like, this is a good morning so far. I needed this. I'm a good dog trainer. I got a good hat game.
That's what I'm here for. Yeah. You didn't say anything to me, so that's something.
You have your tasting afterwards today.
That's true.
That's I'm kind of jealous of that.
We do have
I
an
wish I
apple
had
cider
someone who
tasting
made
later, which
apple cider.
we were just talking to Becca,
Yeah.
our editor,
Shout
and
out
she was
Becca.
giving us some really good feedback around a lot of our interests and stupid things that we do. And she was giving me a hard time about being bougie with my coffee and hating on your gas station quality coffee. And I guess here we are once again saying something quite bougie about me going to an apple cider tasting party after or this afternoon. So I guess I see where she's coming from.
That's what happens when you move out east, man. You move
Yeah,
out
you
east
become a
where
New Englander, you live on the East Coast, that's what happens.
you start disliking the gas station coffee and going to these tastings, and it's probably in a big open like vineyard area, like overlooking the
Right.
Atlantic Ocean. Nice.
We're all dressed in white. We got our sailboats in the distance. Yes, that's how we
Exactly.
do it
Yep.
up here. Yep.
Oh man, but yeah, no. Anyways, that's super cool though, dude. And another plug before we get into, I guess, you've been absolutely killing it at the rock climbing gym. I don't know if we've brought that topic up yet since you've started there here on the podcast, but I figured it'd be good to give you a little bit of the floor here for a second before we get into the podcast content and kind of what you've been up to.
Yeah. For years now, I've been looking for two things. Well, one, to have my own business or a partnership, I should say, with you at this
Yep.
point, but also trying to find a sport that I like.
Mm,
And when I was in PT school, my roommates were really big rock climbers, and they got me into it. I climbed exclusively for probably 3 years, like 4 days a week. That's all I did. I would do calisthenics and I would climb, and I loved it. But then when I started working, doing a lot of manual therapy and trying to climb just beat the crap out of my hands, and I was getting injured pretty often. So I took a break from climbing for a number of years, focused on weight training, and now just like, I don't know, the stars aligned. I was like, I need to figure out, well, where I'm going to work for one
Mm-hmm.
as a private practice therapist, but then also who do I want to serve? And
Yeah.
so it made sense to try to go back into the climbing community. And now I've been climbing again. It's been wonderful. I'm working out of a local climbing gym, and it's been great. So we're just right now I'm treating a lot of the staff members for free just to work on our product and get used to the business flow. But then also they've been referring people to me now. So we have customers from that gym coming to see me for rock climbing specific PT, which has just been absolutely awesome. And it's just like, it feels really good to do.
Heck yeah, man. No, that's sweet. So if anyone's in the Portland, Maine region area and wants to go check it out, Christian is up and live and running out there, so you can go see him.
Sure am.
But awesome, dude. All right, let's get into it. So we have a topic today that is kind of slept on in the rehab world, I think, and we're gonna try and bring some light to it. I know, Christian, you've mentioned how you love this stuff, which is kind of crazy. When you said that, I'm like, you love this stuff? So we're talking about peripheral nerve entrapments today, and we'll break that down and try and keep it lighthearted and fun while we do it. But Christian, first off, what the heck is a peripheral nerve? And then what the heck are these so-called entrapments? What's going on there?
Sure. So you have two major types of nerves. You have your spinal nerves, and then you have your peripheral nerves. So as your nerves are leaving your brain and forming your spinal cord, when they're in that area of your spine, they're called your spinal nerves. But the second they leave your spine and go left and right to go into your torso and your arms and your legs, they now become your peripheral nerves. Depending on what's going on for your diagnosis, like let's say it's a spinal issue like a disc herniation, or it's a peripheral nerve issue like carpal tunnel syndrome, you are going to have different patterns of symptoms. And those patterns of symptoms are how we differentiate between the two kinds of injuries, whether it's a spinal or a peripheral nerve injury. I think peripheral nerves are really fun just because they're massive puzzles. It requires a lot of background knowledge in how the nerves move through your body and all the different potential sites of entrapment, and they make you go crazy. Like that, I think part of the reason people don't like them as clinicians or doctors is because they can be really confusing, but the confusing nature of them is also makes me really excited to work with them.
Yeah, absolutely. Yeah, so no, the peripheral nerves, like Christian said, they can be kind of little pests when you're trying to figure them out. So like radial nerve, ulnar nerve, median nerve, right? Versus, because we know that these nerves, when they pass through the elbow and they go in the forearm, they split into, superficial and deep layers, and they dive every which way, and they have different components to them. For the purpose of today, we're just going to keep it more broad. We won't get like into the nit and gritty specifics of that. Um, but yeah, so peripheral nerves, got that. And then entrapments, kind of what the heck is going on when we hear the word entrapment, or what is the nerve doing or experiencing at that point, right? I think one of the things that I tell patients a lot is nerves like three things, right? They like movement, space, and they need their oxygen. And if you take any of those away, and then you can start to get these different symptoms, nerve type symptoms, and that's when something like an entrapment can come into play. Christian, what exactly, when I say nerve type symptoms, what do you normally tell patients in terms of, or ask patients if they feel these certain symptoms related to nerves?
Yeah, very straightforward. The category of pain is called neuropathic pain or neuropathic symptoms, and it's characterized by pain, numbness, tingling, or burning. Other things you might hear are pins and needles, or the word paresthesia, which is just like the medical word for numbness, tingling, burning. But those are the major symptoms you're going to see. And then in bad cases, so like more advanced, more severe cases, you're going to see muscle weakness. When you start seeing weakness, we are paying very close attention and referring if we need to, if we feel like it's not going to get better timely, because that is quite serious, or it can be, in that if we don't treat it quickly and adequately, that muscle weakness can progress and actually become permanent to some degree. And that is something we want to avoid at all costs.
Yep. Yeah, absolutely. And I think kind of just like a muscle or a ligament, you sprain your ankle, you can have different grades of ankle sprains. And I think a lot of people know that, right? Grade 1, grade 2, etc. You hear it in sports a lot. It's kind of the same thing for like the nerves. And in the sense that like you can have different grades of nerve injury. We don't have the names aren't super important, but it's basically you have like a grade 1, the nerve is kind of hurt. A grade 2, all right, it's pretty hurt now, but it can still come back from it. And then a grade 3 is like we might not get any function back of that nerve because of the damage that's been done. And so, like Christian said, when we start to see muscle weakness, something like that, very important to get the patient out to the appropriate provider to take a look at it, because we don't want that nerve to get too progressed in terms of its injury.
Yeah, and we also like to pay close attention to nerves because of the nature of them. Everyone knows spinal cord injuries are a thing, where you have damage to your spinal cord, which is just a cluster of nerves, and people often have very severe lifelong issues. And it really comes down to the anatomy of nerves. The way they have evolved is they don't heal very quickly, and then when they do heal, they don't always heal that well. And that can lead to long-term problems. And so we have to make sure that, because we know that nerves have a reduced healing capacity and the time can be very long, you want to minimize how much damage occurs in the first place. And if there is some damage, you want to act on it very quickly. And so like this is just like we pay very close attention, like I said, and you don't, like for a muscle, for example, you might be okay with saying, oh yeah, it'll be several months, give it 12 months at most for a lot of things. But for nerves, we're talking on the order of like, if you aren't getting any better in 1 to 2 months, we might need to refer you to a neurologist for some more advanced testing, or whoever else, to get a better sense of what's going on, because we can't sleep on this.
Right. Figuratively and literally, we can't sleep on it.
Are you talking about some Saturday night palsy?
Well, I mean, that's what I was alluding to. Yeah. I guess you could sleep on it. Look at us pulling out
I
the
love that
humor.
term. I
Saturday
totally
night.
forgot all about that term. I want to know what doctor made up that word, because that is such a good name. And
And also,
100%, if you've been a college student,
yeah,
especially, I don't know if you were in a frat, Eric, but I was in a frat and we
I
had a lot
was
of
not in a
fun.
frat.
Yeah, Saturday night palsy definitely happened to a lot of people, and I have had experience with it firsthand.
Oh man, that's funny. No, wasn't in a frat. I got asked to be in a frat my freshman year, and I uh I literally slept on it, and then the next day I said, no, I don't want to do that. I know. I probably missed out on a great time. Who knows? They said they were the stoner frat. They said they don't do anything but just chill and
Probably
and
better you didn't join that one.
I'm like, as an 18-year-old, I'm like, sounds sweet, dude. And then I
I
woke
mean,
up the
all frats are stoner frats, but also you do other cool things. You don't just do that.
yeah. Right. Anyways, yeah. So you mentioned getting to the right providers and doing different tests. I just want to plug this real quick because I think it is important for this topic. Some of you might be thinking, how do we image nerves? How do we look at nerves? How do we know if this entrapment is going on? Well, there's some cool things that we don't do as physical therapists, but as other healthcare providers can do. And that is things called like EMGs, where they put basically needles into the nerves, and it's a conduction test, and they test the conduction of the nerves, and they look at, is that nerve functioning to the normal rate, or is it not functioning at the normal rate? And they can, kind of fine tune where is that conduction site being lost at? And so kind of where's that entrapment site? I know the research article also mentioned something like MRI or ultrasonography, where they can take a look into the soft tissue of the muscle, or around the muscle, around the nerve, and try and figure out, is this being compressed here? But the big one for me, I would say, Christian, is the EMG. That's what I always see. If a patient is starting to show weakness, or if their nerve symptoms are getting worse over the course of a month to 2 or 3, I always see them going to get an EMG test and trying to figure out, all right, what's going on here.
The only thing I'll add to that is that there are two major nerve tests. There's the nerve conduction velocity test, and there's the EMG. The nerve conduction velocity test looks at the signals going through the nerve itself and measures those, and based on the changes in those measurements, the neurologist can decide what's going on. And then there's the EMG, which looks at the function of the muscle. So the nerve has to send signals to the muscle. And then based on the EMG test, which looks at the muscle function itself, the neurologist can decide something is going on or where or whatever else. But they're two different tests for those out there, but they both have a lot of clinical utility, can tell us a lot about what's going on.
Yeah, that's a good point to bring up. Yeah, differentiating between that, because I definitely think I crossed those lines without making that super specific. But okay, awesome. So let's kind of move on next, Christian. Set the stage of what the heck this whole nerve entrapment is. Now let's get into more of the fun part where patient comes in and they have arm pain, right? What are you looking for when you're trying to differentiate between maybe something that's muscular in nature versus something that's nerve in nature when you're first evaluating the patient?
Well, that's a good segue into a recent patient story that I had that
There we go.
highlights the complexity of these issues. And I will answer your question at some point, but I may forget, so ask me again if you have to. But anyway, so I recently had a patient who was referred to me for cervical radiculopathy, which is, let's say you have a disc herniation, you have stenosis in your neck. It's compressing the spinal nerves, and that gives you certain symptoms. So he was referred for cervical radiculopathy by his primary care doctor. And mind you, this patient is also a retired heart surgeon. And so he's very aware of nerve symptoms, especially nerve compression that can happen in the neck and your chest, because he's literally had to operate on these types of nerve compressions before. So his chief complaint was total hand numbness and neck pain. And this is highly important. The number one thing you want to pay attention to when differentiating between what nerve could be involved or is it nerve versus muscle is the distribution of the symptoms. The places the symptoms go or are tells you so much. And that can indicate whether the issue is a peripheral nerve entrapment or it's a, let's say for this person, a multi-level cervical radiculopathy, which is honestly quite rare. So for this patient, all of his radiculopathy tests were negative, and the only thing I could do to make his symptoms better or worse was doing deep tissue work to his upper traps and his scalene, so like just all the stuff on the top of his shoulder and the side of his neck. Given his age though, so I think he was in his early 70s, cervical radiculopathy is very likely. It's very common the older you get. And so I figured his symptoms were probably going to be a combination of that plus thoracic outlet syndrome, which is where your peripheral nerves are being compressed in your neck or your chest after they've left your spine. And so we decided to treat both. And he was getting better very quickly over the course of a handful of treatments with me just working on his neck, doing a bunch of massage and stretching and general exercise of his neck and his shoulder girdle. But then he went and saw our interventional pain specialist at my company, who was a spine specialist. They're an anesthesiologist by trade. And they said the symptoms were probably mainly due to cervical radiculopathy. And they recommended a nerve ablation, which is where you go in and you snip the nerve basically so the nerve can't send signals anymore. And so usually it makes you feel a bit better. But this patient also had an upcoming neurologist appointment. And so he wanted to hold off on the nerve ablation until he got more information from the neurologist. And all the while, we keep treating for several more weeks while he's going through the motions here, and he's still getting better. And I'm still just focusing on all the stuff I said about massaging and stretching and strengthening, and he's getting better. So then he sees our neurologist, and they do nerve conduction velocity testing, and I think EMG testing. And the neurologist says that we are all wrong. The primary care doctor who referred him for cervical radic, I, who said probably radic and TOS, or thoracic outlet syndrome, and the anesthesiologist who said cervical radic. And the neurologist was like, you're all wrong. It's carpal tunnel syndrome. I'm like, what the hell? How are we going from cervical radiculopathy to carpal tunnel syndrome? But anyways, so mind you, this patient has been with me for probably 5 or 6 weeks at this point, once or twice a week. And he's still getting better. His symptoms are almost all gone. His hand symptoms are getting a lot better. His neck pain's very mild at this point. And so we ended up discharging. I'm like, dude, I think you're doing pretty well. He was excited. He's like, I feel good. But he is going to move forward with getting a carpal tunnel release just because why not? He seems fine with it. So I'm not going to argue with that. But the point of me sharing this story was to highlight how such seemingly simple symptoms like total hand numbness and some general neck pain can be really tricky to nail down, and they can lead several different highly qualified physicians to give different opinions and contradict one another. And this is just the nature of nerve stuff. It's really confusing.
Absolutely. No, that's a great story. And I'm glad that the patient was getting better. And yeah, I agree. It's pretty wild about, like you said, how nerves, they can take you down some pretty weird paths in terms of like, I feel like they can almost make you think, a patient will come in and it just doesn't present quite right. If it's like a tennis elbow, or maybe if it's some wrist pain or something, you're like, it just doesn't seem quite like a muscle or a joint issue. And I feel like sometimes nerves, you can just start being like, well, yeah, I can, I think that could come from a nerve. That could probably be nerve related. Like they just always are chilling. They're like, I don't know, they're like an eel, just chilling below the surface, just causing little waves. But no, no, I think that's the, and to get a little bit more specific, let's get a little bit more specific now. I have a similar patient story that will be very quick, but let's talk about the radial tunnel, or where the radial nerve can be entrapped. So I mentioned the tennis elbow. Some people might have heard of it as like lateral epicondylitis, epicondylalgia. All these different terms are out there, but tennis elbow, most people know what that is. When what's called your radial nerve comes from the back of the arm and kind of goes on the outside of the elbow, it kind of dives into these different muscles on the outside of that elbow there. And again, what can happen, like we've talked about, nerves can get entrapped. And so it's very close to where that tennis elbow is normally felt. And so oftentimes we can have, people thinking like, oh, this is just tennis elbow, go do X, Y, and Z. And we'll talk about treatment here in a little bit. But really, it's that nerve that's getting impinged upon, entrapped, compressed, whatever you want to use. And like Christian said, there's different signs and symptoms that we want to look for in terms of sensation loss, numbness, tingling, burning, versus pain at the elbow with like muscle resistance if it's coming from something like tennis elbow. So fast forwarding to the patient I had, sharing them with a orthopedic PA, and I messaged the orthopedic PA and was kind of like, hey, I think this seems to be like maybe peripheral nerve entrapment, or could just be an irritated muscle. Like the patient was honestly testing pretty negative with a lot of stuff. And then the PA saw her, and the PA came back and was just like, yeah, I think it's probably radial tunnel syndrome, but I also think it could be medial and lateral epicondylitis. And and it's like there's a lot of stuff being thrown out there in terms of what could the differential diagnosis be. But as PTs, this is where I would say we fall back on our different tests and measures and whatnot that we try and sort out through, right? And so, long story short, I'm going to see her back in the clinic. I think it's personally probably more than likely going to be the radial tunnel syndrome or that radial nerve entrapment, just because a lot of the tennis elbow stuff didn't quite fit the book, I think, for treating that. But one of them, like we talked about, there's 3 major nerves we're going over. One of them is that radial nerve that can present like tennis elbow, but usually, if it is more the radial nerve, they're going to be lacking some of the subjective report for tennis elbow, like maybe they haven't been playing tennis at all, or maybe they weren't doing repetitive activities that would make you think, well, yeah, this is probably some type of pain and tenderness due to that tennis elbow, versus something like a nerve entrapment. So that's my whole spiel on the radial nerve and how it can be similar to tennis elbow. But yeah. Anyways, going forward, we have 2 other sites to talk about, Christian. Let's talk about the ulnar nerve and going more into the inside of the elbow. What would people experience? What would people feel like if they felt something more from the ulnar nerve entrapment?
If you're going to have entrapment at your elbow, it's going to be near your funny bone, and it's called cubital tunnel syndrome. So on the inside of your elbow, everyone probably has felt it before. If you have compression of that nerve, whether you bumped it quickly or there's some swelling in there or the muscles around it are very tight, you're going to get numbness, tingling, or burning, typically in your pinky and your ring finger. That's the hallmark area of where your ulnar nerve goes. The one thing to think about with that one, though, is going to be whether it truly is cubital tunnel syndrome happening at the elbow, or if it's actually happening in your wrist. There's a canal which is right next door to your carpal tunnel on your pinky side of your palm called your Guyon's canal. And your ulnar nerve also goes through there. And with really bad carpal tunnel syndrome, you can also get some pinky symptoms. But one common way people will get Guyon's canal syndrome is cycling, or they fall on their hands. So cyclists often are riding in the drops and they have a lot of pinky side of their palm pressure. And I learned a new term, Eric,
Mm.
cyclist palsy. I didn't
Oh
even
yeah.
know that term, but it makes a lot of sense. That is one of those differential diagnoses that we pay attention to, but generally that one's pretty rare. You're going to see cubital tunnel syndrome a lot more often than that one. And I had a patient, might have been 6 months ago or so, that had a past history of an ulnar nerve transposition. What that
Mm.
means is that as his ulnar nerve is going through that groove, his cubital tunnel on his inside of his elbow, it was moving in and out of that groove a lot. He just the way he was born, his anatomy was such that the nerve didn't stay put, and it was causing him a lot of grief. And so he had surgery to relocate it so it took a better path and would stop bothering him so much. But ever since then, he's always been prone to irritation of that nerve. And so he was doing a ton of pull-ups, a ton of muscle ups, and just trying to like get really good at those two things for a while. And you can imagine doing a muscle up, that's a ton of elbow, ton of forearm, and he was having loads and loads of pain start to happen in that inner elbow. And then he was getting a ton of ulnar nerve distribution symptoms into his pinky and his ring finger. And given all his history and stuff, I started working on his forearm a lot, doing a lot of deep tissue work. Of
Mm-hmm.
course, telling him to lay off the muscle ups and pull ups for a while and focus on other things that were not going to cause his symptoms. And he was getting a bit better, but it was happening slowly. This was over the course of probably 2 or 3 weeks. He went to go see a sports medicine doctor who said, yeah, that could be part of the problem, that area that you've been working on, Christian, but also I think he might have thoracic outlet syndrome.
Mm.
And they wanted us to work on his neck and his pecs as well to see if he has nerve compression happening there. And as soon as we added more work to his pecs in particular, so stretching and massage work, his symptoms began to get better even more so. That story serves as a reminder that when it comes to nerve entrapments, you need to look at the entire nerve pathway because there's such a thing called double crush syndrome, where because your nerves, as they leave your spinal cord, they leave like actually the spine structure, I should say, and they go down to your fingertips or your toes, they are one long giant cell. And because of that, if you compress them high up or compress them lower down or in the middle, anywhere in between, you can get symptoms across the entire path of the nerve. So a compression in your wrist could give you symptoms in your upper arm, for example. That's less common. It's usually going to happen at the site of compression, but it can happen. And so
Mm-hmm.
when it comes to helping these folks, if you're just focusing on the site of pain, you could be missing a lot of potential issues that could be happening above or below with different sites of nerve entrapment. And so we have to always make sure that we're just keeping an open mind with where things could be coming from and treating everything, especially if you notice that you're not making the progress that you want there.
Yeah. Yeah, really good point there, the double crush syndrome. And that's something too that's kind of interesting. You mentioned it's one long cell, or, the nerve going out of, let's say, the neck to the hand. I mean, it's all, and we're going to talk about this when we talk about maybe some like nerve glides and whatnot, but it's all connected. Right. And the reason why these nerve entrapments are particular at risk, or these nerves are more at risk for these entrapments, is because of what Christian just talked about, how there's this one long piece of tissue, but doesn't have like stop and starting points or breaks or stopping at joints and whatnot. No, it goes around that, it goes through that, it goes through the muscles, and there's many different points where it can become entrapped. But no, that's a really good point to bring up with the double crush syndrome there. So then last thing that to bring up is more the median nerve. Christian talked about that with his story with the carpal tunnel syndrome, right? And having the carpal tunnel release. But that median nerve can also get entrapped higher up, just in front of that elbow. So kind of like think about more front of the elbow. We've been talking about the radial nerve being on the outside, ulnar nerve being on the inside by your funny bone. Now kind of split the diff and you're going to get that, that median nerve where it can be entrapped. Now, from my understanding, Christian, the being entrapped here is much more rare, I would say, especially compared to the carpal tunnel, but even to the ulnar and radial nerve on the inside and outside. But this is where it can get entrapped at the two heads of that pronator teres muscle. So what patients are going to feel, like we've been talking about this entire time, sensation loss, shooting pain, burning pain, weakness of the hand. So a lot of median nerve stuff is going to be that grip strength, right? So carrying a milk jug, carrying groceries, and you're feeling like, man, my right hand, I just can't hold on to this heavy bag of groceries like I can with my left hand. That could be a common report that patients might have.
Yeah, I actually think that's good to stay on because oversimplification of differentiating between muscle and tendon pain or weakness, I should say, and nerve weakness is pain when you test the muscles themselves. So if you have tennis elbow and you test someone's wrist extensors for strength, it's probably going to hurt. It's going to hurt that tendon or that bony attachment or even the muscle itself if that's what's sore. Now, if you have weakness in those wrist extensors and you're looking for tennis elbow and you go and test and it doesn't hurt, but it's actually still weak compared to the other side, that makes you feel like it's probably a nerve, because nerve weakness usually doesn't hurt. The pain you get is more from the nerve being compressed, not from the muscle being used. And so that really helps us distinguish between a muscle or tendon issue versus a nerve issue. It's not perfect because, like Eric is saying, especially with pronator teres syndrome, as a median nerve comes through, you can be getting the motor and the sensory components of the nerve compressed up there, and that can give you pain and weakness. And if you go and test the pronator teres there, it might hurt, and that can be kind of confusing. This is why you got to look at the whole picture, talk about the whole history, and based on all that, you can start to really clear things up. I do have a story about pronator teres syndrome, but before that, Eric, anything else you want to add to that?
No, I think that's a good point to bring up. Is looking at the system as a whole and not getting too convoluted in all the little details around one area. Because it is easy to get lost in it, right? Especially when we're talking about something like peripheral nerve entrapment versus a tendon issue, muscle issue, joint issue, cervical radiculopathy issue. You got to step back and look at the whole picture. It's almost sometimes I feel like a diagnosis by elimination, where you're like, all right, it's not tennis elbow, it's not cervical radiculopathy, not a bicep strain. And you kind of just keep checking off the boxes of what you know it not to be. And then you might settle on, all right, they have a little bit of weakness that isn't painful and it hurts to the touch around that outside of the elbow. Hey, maybe this is a radial tunnel syndrome. So anyways, that's all I wanted to add. Christian, floor is yours for the story.
Cool. Yeah, you said that pronator teres is quite rare. That's totally true. And that's really the same thing for all these nerve entrapments. They are, by and large, rare. And what you try to do is you always want to be looking at every other diagnostic option possible, because those are usually much more common. And so you try to make your diagnosis by exclusion. But, a telltale thing about a nerve issue is going to be numbness, tingling, or burning. If you have any of those symptoms, we're definitely thinking about a nerve. High suspicion there. But so to my story, some years ago, I had a CrossFitter who was getting numbness, tingling, and burning in his thumb, index finger, and middle finger. And it was happening during his cleans or when he was in a front rack position doing his front squats. And he'd been having this issue for well over a year. He'd been to a doctor or two. He went to a chiro. I don't recall what he told me they thought it was what it was, but all I know is nothing was really helping, whatever they were doing. And he didn't have a clear thought about what the hell was going on, what he should be doing about it. And so he was seeing us as a last resort. And I just recall that I'll never forget this guy. He couldn't fully turn his palm up. So your pronator teres, the way it works is if you start with your palm up and you go to turn your palm down, that is what the pronator teres does. It turns your palm from up to down. If you can't turn your palm all the way up without like moving your shoulder weird or twisting your body around, you're probably really tight in that pronator teres, and that's going to make me suspicious of that being an issue. And he just had no mobility there with that supination motion. And so I just hit him with a ton of deep tissue wear, stretching, and I gave him some exercises of the area, but not with the goal of getting him stronger, more with the goal of them being like a dynamic stretch, just kind of an active movement to loosen things up. And I think I saw him for 3 or 4 sessions, and he got nearly all the way better. So all we had to do was just make that area calm down, loosen up, give him some education about what I thought was going on, how to attend to it, and he made dramatic improvement very quickly. And that just goes to show that a lot of the times these issues can go missed because people just don't always know about how all these things work. But the treatment often can be quite simple once you know what's going on.
Yeah, absolutely. And I think that's a perfect segue into how the heck do we treat this thing? And so we'll get into some discussion here now. So yeah, those are kind of the 3 major parts we wanted to break down before we do get into treatment, discussing the different sites around the elbow where we can see this nerve entrapment. And I think it is good just to be as a reminder, like Christian said, these things are not as common, definitely not as common as your other orthopedic injuries around that area, but if you're treating tennis elbow and it's not getting better, and we're pretty sure it should be getting better, it's something else to think about, right? Is this a radial nerve entrapment, or so anyways, let's talk about treatment. One of the things that so I like to do, Christian's already mentioned it, I've always found that stuff like soft tissue massage or different types of manual therapy to that area, to try and lessen the muscle impact on the nerve, right? If I'm suspecting that this is coming from, let's say, pronator teres or wrist extensors on that lateral epicondyle, and then, yeah, I like to work those muscles out, and it just feels good for the patient. If you have a sore forearm and you can give some tissue work in there, patients generally really like that. So manual therapy is one of the approaches that I'll choose when working with this. And second to that, I like to try and basically give stretches to the nerve, kind of like you would give stretches to the muscle, right? So these are traditionally thought of as like if someone has sciatica, you might have like a sciatic nerve glide, or if they have a cervical radiculopathy, you might do a median nerve glide. Within these areas, there's different positions you can put the forearm into that's going to stretch and then relax either the ulnar, median, or radial nerve. And so I like to give those to patients, because the idea is that the nerve travels through the muscles and the joints, etc., like a train going through a tunnel, right? And if that tunnel gets smaller and smaller around the train doesn't move as well. And so if we can try and get the train to move more efficiently within the tunneling system that is provided by the body, in theory, we should be able to see improvement in the symptoms. And so I like to try and quote stretch the nerve out with those different nerve glides. I might give some type of resistance exercise or active exercise to those muscles. That's not really as much of a goal of mine in this scenario. Sometimes I'll do it just to make the patient feel like they're doing more work almost, but it's not, like I said, as much of a goal as mine. Now, if they have more progressed symptoms and they're having weakness in that area, right? Maybe it is a higher level nerve injury. And then maybe we do start looking at some type of active recruitment for those muscles that are innervated by the nerve to try and get those working a little bit more as that nerve gets more freed up. And then lastly, what I'll do, Christian, and you know me, I'm going to throw this in there, I'll do some dry needling to the area as well. The forearm, it's a super safe place to dry needle, and it's something that has very little risk and high reward to do. It's quick, it's easy, as long as the patient doesn't freak out around needles. I've had several success stories with dry needling the forearm, specifically the extensors of that wrist that come up to that elbow. And so think about it. If we have radial tunnel syndrome and those common wrist extensors are cramping down on that radial nerve, and then if you get those wrist extensors to kind of free up a little bit, that might make the nerve symptoms a little bit better. And so that's another thing I'll throw in there as well, as some dry needling into it. But that's my outlook on treatment, Christian, when it comes from a PT perspective. And now I'm excited to hear what you have to say, because I think you've been doing this longer than me, and I'll say it, I think you've been doing it better than me. And so I'm excited to hear what you have to say and glean some knowledge from you.
I don't really have anything different to say about what we do for treatment. That's exactly what I do, but I'll elaborate. When it comes to thinking about how to help people with these nerve entrapments, when you look at the research and you see what all the prominent voices are saying about this, all the research boils down to is do physical therapy or put a splint on so you don't compress or tension the nerve as much, so you give it a bit of a break, things like that, or do surgery, But when people in high quality research say do physical therapy, it isn't helpful. It doesn't, like, there's so many things that physical therapists can do. And we all have different opinions on what's effective. Well, the reason saying physical therapy isn't helpful, and then the reason that we have different opinion, is because we don't have clear guidance in research about what has to be done. And I think that's largely because, not because people aren't trying, but because the nature of the things that we do vary wildly in the way you do them. So when someone says do massage, from person to person, that's going to be a very different experience. Someone might be doing massage very superficially, so gentle, sweeping motions. Other people, like myself, get their elbow in there and beat the crap out of you, because I feel that works better in almost every circumstance if you can take it. Or people like Eric put needles in you because from his experience and truly in some research does help to loosen tension in muscle. And so when it comes to thinking about how we help people, what we do, we're operating from like a system of thinking. What do we think is going on? What we think is going on with a nerve entrapment is the nerve is being squished. It's being squished somewhere. We have to figure out where it's being squished, why it's getting squished in the first place, and then what treatments do we know to work from research, but also from clinical experience, and maybe more from like lower quality research, like case studies, sharing opinions from clinician to clinician, like we are right now. You put all that stuff together and you figure out, how do I decompress this thing? And almost always my mind goes to, well, I can't change your anatomy. I can't make your bones smaller. I can't change the bony grooves things go through. I can't change the scarring you might have on a nerve or in the fascia. But what I can change is I can change the muscle tone. I can change what you're doing that could be causing increased muscle tone in the area, like repetitive movements such as like office work and causing carpal tunnel. And so I focus my efforts on one major concept, which is make the muscles around the potential site of compression loosen up. And I use all the things that I know that can do that. And that largely entails massage of some kind, stretching of some kind, whether it's the muscles in that area and or the nerve, like you were describing, Eric. And I just change what you're doing to that area so you stop beating the crap out of it. You put all those things together, almost always good things happen. But the last thing I'll say is, like I mentioned earlier with a lot of these difficult cases, you can't just rely on treating one single site, because that nerve can be compressed at multiple sites and those other sites can be causing your symptoms. You need to take a broader approach and focus on treating the whole arm or the whole leg, because chances are you will miss something. You'll leave some gains on the table if you just focus your treatment on one particular spot.
Yeah. Yeah, that's a good point to bring up too, is looking at the individual as more of a whole as well, and not just a forearm or pronator teres, whatever it might be. Yeah, I feel like another big part where PT can come into play, because you're right, Christian, the research is, it's like conservative treatment, do physical therapy. Like you said, it's
It
like,
means nothing.
what is that even? Yeah, like just might as well not even include that. Just have them come to PT and let us try and figure it out. Which I guess is kind of what happens. At the risk of sounding a little arrogant, but I like how you mentioned looking at the patient as a whole. I think another big part that PT comes into play is just education. Education, like you've alluded to several times now, activity modification. Some of the best work I think that PTs do is without even putting hands on sometimes. It's how we talk to the patients. It's how we educate. It's how we discuss what to do and what not to do when it comes to daily activities. And I always stress to patients, well, these activity modifications, they're not a forever change. It's not you're never going to be able to do pull-ups again. It's just for the time being, we have to chill out a little bit. And I think maybe not more times than not, but I think more than we realize, if we just give the body what it needs in terms of activity modification, the body does a pretty dang good job of healing itself. And we see that in low back pain, right? And so I think if we can just look at the patient subjectively and say, all right, you're doing a lot of pull-ups and muscle-ups. Let's chill off on that for a couple of weeks. And it just gives the body room to breathe. And I think more than we appreciate, the body does a really good job of healing itself. I think a lot of times, it's a little bit of a rant, a lot of times as medical professionals, we think we need to step in because we think the body isn't capable of doing it itself and it needs an extra push. And I think in the rehab world, that I don't think we give enough appreciation to the body and how it can heal itself. Now, if you got something like an infection or cancer going on, that's not what I'm talking about. Go see the medical professional for that. So yeah, no, it can be a tough one though, right? There's no doubt about it that this can be a tough rehab for the patient and the clinician, but everyone's different. Find what works for that person, and more times than not, people will get somewhat, if not significantly better.
Yeah, very well said. A classic example that's not the elbow is when people get sciatica.
Yeah.
We see people in the clinic all the time who get sciatica down, from their butt down to the back of their leg from sitting too long, taking a long drive. They're on an international flight and they come back and they're freaking out, and now they're like back to their desk job and it still sucks.
Mm-hmm.
And they're just like, what the hell is going on? Like something's broken. Like I must have a herniated disc. I'm like, look, This isn't going to blow your mind, but my advice to you is to get up and walk around a bit more. Get off your butt. Your nerve needs to breathe. Because what just
Yeah.
happened was that you sat on your ass for too long. Your sciatic nerve got sore from it, and now it's giving you all these weird symptoms. And if you keep sitting on it again and again and again, you just keep poking the bear. Just stop poking the bear for a while. Move around more often, or instead of sitting in your chair, lie on the couch if you're working from home, or like change desks if you can at work. Change something about the way you're compressing the nerve so that it can get a chance to breathe and recover on its own. And again, none of that is rocket science. It's just sometimes that very simple advice is going to help you get better, way better than me doing deep tissue work, for example.
Yeah. Yep. Absolutely. Yeah. That's something else to keep in mind too. Just like how we can have these nerve entrapments at the elbow or the wrist, right? Or the shoulder. I mean, it's no different than having some sciatica because I think a lot of people know about how the sciatic nerve can have different routes through the piriformis. It can go under, it can go over the top, it can go through it, right? It can split, and that piriformis can cause nerve entrapment of that sciatic nerve and cause sciatica. It's the same thing like the elbow. It's just for some reason, when it comes to the elbow, the nerves are a lot smaller. They have weird names. They do different things. Whereas like when it's the sciatic nerve, it's like sciatica and comprehend this. It's easy. But it's like the same thing, just at a different spot.
The arms are just more intricate. There's just a lot of stuff smushed together in closer proximity, and there's a lot of overlapping symptoms, and so the puzzle can be tricky.
Yeah.
The sciatica puzzle is pretty easy. The nerve entrapments in the arm, I think, are a bit trickier to sort out. But then
Oh,
again, you
for
get
sure.
weird ones in the leg. You get like peroneal nerve entrapments in
Mm-hmm.
runners, or you get like medial plantar nerve entrapment for people who are standing or running too much in the bottom of the foot. So like these little things can also be tough to figure out in the lower leg, but they're just fun. I love nerding out on them. It's like one of my favorite things to do. I forgot how much I love nerve entrapment.
Until we started doing this, until we did the podcast, man. No, that's good, dude. That's good. Yeah, I think that's trying to think of other time. I think that's it. Did we cover
I
everything when
think
it
we
comes
did. I think
to
that's more than enough information. The only thing that
perfect?
I would leave people with is that if you're wondering if you have a nerve entrapment, if you have numbness, tingling, burning, you probably do somewhere, and that's a good start with talking to your doctor or your PT or your chiro, whoever you're seeing.
Yeah, yeah. If it looks like a duck and quacks like a duck,
Just like your dude,
just like that.
that was a good plug right there.
Right, appreciate it. Hey, Waggle, sponsor the podcast. Giving you free advertisement. No, yeah, that's awesome. Everything you didn't think you wanted to know, but now you do know about nerve entrapment, and especially, I think the big thing, if you start having weakness and it doesn't hurt, I would reach out, reach out to Christian or I, or reach out to your primary or chiropractor. Yeah, if you have weakness and there's no pain, let's get that checked out.
Yep, sketchy.
Sketchy, yeah. All right. Well, that sounds good, man. Best of luck with everything going on today. Have fun at that cider tasting, and we'll be back next week.
Thank you.
All right. See you
I'll
guys.
send you pictures from my sailboat.
Better have those Sperry's on.
All right, later, dude.
All right. See ya.